So, good evening, everyone. I'm Dr. Shailesh Gupta, consultant minimum access pediatric and robotic surgeon from Max Patparganj, Vaishali, and Noida. Today, I'm going to present one important topic, cryptorchidism. So, why it is important? Number one, it comes as a part of three specialties: pediatric surgery, urology, and general surgery, and it is the commonest congenital condition of male genitalia, and it can also come as a short case in your viva, and definitely it can be a question in a theory exam, and it is a very interesting topic. So what my aim is to make this topic as interesting as possible. Isolated cryptorchidism is the most common congenital anomaly of male genitalia. That is the bottom line, right? And approximately 33% of the premature male infant are cryptorchid, right? One third of premature baby have cryptorchidism. That is a big number, right? And the incident seen in the full term male is at birth is 2 to 4%, and which decreases to 1% at the age of 1 year. Moving on, unilateral cryptorchidism is more than twice as common as bilateral cryptorchidism, which is 68% is unilateral and 32% are bilateral. And right sided is affected more often than the left side. 70% of unilateral cryptorchidism are right side. The basic is there is a faulty descent during embryonic development. This is the basic common fact of cryptorchidism, right? So faulty descent could be of three type, right? There could be a halt along the normal descent path. So it can lead to undescended or retractile testes, or faulty descent means the testes have traveled off the normal path, which is known as ectopic testes. And third is testes never developed or die in between. That is absence testes. Small diagram which shows you on the red means it is a normal path. It is halted before that. It could be abdominal, it could be inguinal, it could be suprascotal. And pink means it is wander off from the normal path. So it is an ectopic testes. It could be prepenile, superficial ectopic, transverse caudal, femoral, or perineal. You need to understand the exact embryology which take place in the development of testes, which take place in the testicular descent. So testicular descent in the prenatal state can be divided into three parts. Number one, transabdominal migration of the testes to the internal inguinal ring. Second stage, development of processus vaginalis and the inguinal canal. Third is transinguinal descent of the testes to the scrotum. So let me discuss the first step, that is transabdominal migration. So it starts from 6th gestational week and stop at 12th gestational week. At the 6th gestational week, testes is located ventromedial to mesonephros near the inguinal region. So despite the fetal and abdominal cavity enlargement, the testes remain relatively stationary. Simultaneously, the ovary ascend during the development. So it is a very important point, my friends. Male and female, there is a different movement of gonads. In male, the testes remain relatively stationary, but in the female, ovary ascends during the development. This is happening differently in both the sexes. Answer is gubernaculum. Gubernaculum found in the male sex facilitate differential movement. It is a gubernaculum ligament at 6 week become more muscular, become more stout. And why this happen? Because it happened because of INSL3 testis hormone secreted by testes, right? And whereas in female, this ligament remain thin, flexible, and lengthened with fetal growth. That is why it is not able to stop the ovarian ascent. At this stage, at the development of process vaginalysis, the inguinal canal is getting formed. So a pathway is now being established so that on the third stage, testes can pass along this path and goes to scrotum. Third part is the transinguinal descent. This is the final embryological part of testicular descent. This happens rapidly, typically happen between 24 and 35 weeks of gestation. Testosterone plays crucial role in this by reducing the tragicity and viscoelastic property of a large gubernaculum. So it is important to know that this transinguinal descent happen in the prenatal stage, but it also happen in the postnatal stage. So it is important to know that two-thirds of the cryptorchid neonate experiences spontaneous postnatal testicular descent, usually within 6 months. This postnatal descent, the postnatal descent, is triggered by the surge in testosterone during the first 3 months postnatally. Why this happen? Because there is an activation of hypothalamic pituitary axis, which happened due to loss of negative feedback of maternal endocrine environment. So there are certain factors, mechanical factors, which regulates this testicular descent, which impact the testicular descent. One of the most important factor is androgen and the androgen receptors. It is seen that intact hypothalamic pituitary axis is essential for normal testicular descent. Boys with hypogonadism or androgen insensitivity are likely to be affected with cryptorchidism. So now the second hormone is insulin-like factor and receptor. As I told you earlier, in the first phase, that is trans-abdominal migration of the testicular descent, INSL3 and receptor LGR8 are the critical factor for trans-abdominal phase of masculinizing the gubernacle outgrowth. The next factor is estrogen. Estrogen is negatively associated with the testicular descent. Estrogen has a negative impact, androgen has a positive impact, and insulin-like factor had a positive impact. Now, I'm going to discuss the each category of the cryptorchidism in detail. And the first one is undescended testes, which is most common a part of a cryptorchid.